At Blue Cross and Blue Shield of Texas, we understand the value of uniting in conversations that can bring clarity and guidance to our healthcare industry. That's why we're proud to join efforts with Texas Tribune on public forums like the one you're about to see.
Please join me in welcoming Congressman Burgess, Representative Howard, and Commissioner. So after all that run-up, let's get right into it. And I want to start, Congressman Burgess, with you, since we have been engaged for several years, and of late, really, for the last month intensely, in a discussion about the status of the Affordable Care Act. It is constitutional according to the Supreme Court. The president was reelected, and so we think that means it remains the law of the land. But as you know, Senator Ted Cruz, your Texas colleague in Congress, has led an effort over the last little while to defund the Affordable Care Act. If we can't repeal it, let's at least defund it. Let's basically make it an irrelevant piece of legislation in terms of its ability to be implemented. Can you update us on the status of that effort, kind of where we are?
The short answer to that question is yes. I do need to start out with a disclaimer. For anyone in the room who is in charge of your HR department, if you own or run your own business, I urge you to get professional help as far as the implementation of the Affordable. I don't mean psychiatric help. I mean CPA.
Although we'd be forgiven for thinking that that's what you meant.
This is so complex and so far-reaching, and as part of what I did earlier this month, I had a series of healthcare roundtables around in the district. There was a gentleman who came from the Department of Labor who now worked as an outside consultant, but he presented all of the things, the compliance aspects of the Affordable Care Act that are coming in the very near future. I knew them all, but I had never heard anyone present them end to end to end. And you could see the faces of the people in the room were really deflated by the discussion that they were hearing. Almost no way to keep up with this degree of complexity. So if that is your responsibility in life, again, I urge you to look into it and see if there's not some professional help that you can hire to help you through this process. And then the other downside is it is changing rapidly, changing as we speak. You saw the things that happened right before the 4th of July weekend. Let me make a prediction. 6 p.m. Eastern Time, Friday evening, right before the Labor Day holiday, some big chunk of the Affordable Care Act is going to be thrown over the rails, and everything will change. I don't know which piece it is. I just know that what I have followed the implementation of this, watch for something big to happen when no one is paying attention. And by definition, that would be 6 p.m. Eastern Time going into a 3-day weekend. What happens in the next couple of weeks in the United States Congress vis-a-vis the funding or non-funding of the Affordable Care Act? Right after the last continuing resolution passed in the middle of March, there was $1 billion taken away from the implementation fund for the Affordable Care Act. $365 million taken away from the implementation from Department of Treasury, from the IRS. This made things tough on the secretaries of those two agencies, and they complained about it. And they moved some monies from other places that they had monies to move to proceed with their implementation. Every conversation I have had with my leadership since that time has revolved around, we are coming up to a pivot point. There is a nexus where the fiscal year ends and the very next day, open enrollment on the exchanges is supposed to occur. Will everything be up and running at the time that it is appointed? I don't know. No one can know that. But I do know that and I'm speaking just for myself, not for Republican leadership, not for the Republican conference, but I have felt for the last 6 months that if there is an opportunity, this will be the opportunity. So I don't think Senator Cruz is exactly wrong about that. Historical precedent would tell you, how did Harry Reid stop Yucca Mountain? He couldn't stop Yucca Mountain because the money for the building of Yucca Mountain was actually taken from each of us as electricity ratepayers, and it's been done for a couple of decades. So the dollars were there in this fund that ratepayers had contributed to. He stopped Yucca Mountain by not funding a line in the Department of Energy's appropriations bill that paid for the license application for Yucca Mountain. So by pulling the funding for the license application, the whole project was brought to a complete
So if you
standstill.
can't go through the front door electorally and defeat the president, if you can't make the Supreme Court see the value of busting the Affordable Care Act as unconstitutional, at least you can use a procedural technique.
And the reason
the
reason it's important, because I mean the comment about 40% of the people think it's already been repealed. The degree of complexity is something that no one is prepared for. I was told in a congressional hearing just a few weeks ago when I asked about what will the rate be, what will be the rate charged for the bronze level plan for the lowest risk individual in the state of Texas, and no one could give me that answer. I was told it would be available September 15th. If you go to healthcare.gov this morning, the little banner you see up in the corner says plan and rate information will be available by October 1st. This is a big deal for people. People are trying to make their decisions about what kind of coverage to have for their families. What about the fact that employers will no longer be required to cover spouses and families? What contribution to the numbers of uninsured is that going to create? There is enough uncertainty surrounding this thing that I think the will of the people, in fact, they will be asking questions about why are you continuing? You've had 3.5 years, billions and billions of dollars, entire federal agencies devoted to the implementation of this thing, and you can't get it right. My degree from across the street was actually in management. I learned there that sunk costs are sunk costs. You can never get them back, but you darn sure don't want to sink more money after good money after bad.
Let me ask Representative Howard, who I think as a member of the minority party in the Texas House, you heard a version of this scaled down, I suspect, during the conversations in the legislature this time. A lot of opposition to the Affordable Care Act in principle and to the idea that somehow we're going to be obligated to embrace key components of it and address our problems. Do you take issue with what Congressman Burgess said, the complexity of the act, the fact that a lot of moving parts, things are changing? There is a lot of uncertainty.
Right, I definitely do not take issue with that. I totally agree with the congressman on that point. And in fact, as you know, we were doing a little Twitter chat this morning,
Yep.
and Evan tweeted something about reserving the hard questions for the congressman, who tweeted back as if the unknowns were knowable, and that's true. I mean, I think we all know that there's a lot of confusion, a lot of we don't even know what to expect is going to be happening, and I think that certainly creates a lot of the uncomfortableness with moving forward. I totally understand that. I think it is curious, though, Evan, that one of the things that our governor said was that actually Texans know all too well what this is about, and that's why they're opposed to it. I would take issue with that, because I think clearly we don't know what's going on. There's a lot of unknowns here.
Yeah.
That being said, the alternative of doing nothing is not an option, in my opinion, and I'm not hearing what those options would be if we stopped this. The fact is that everybody knows we have the highest uninsured rate in the country here in our state, that we have around 6 million people that are not covered, that we are paying for it already, one way or another, with our local property taxes and with higher premium rates to cover uncompensated care. We know that we could have, if we expanded Medicaid, according to Ray Perryman's study, according to former revenue estimator Billy Hamilton's look at this, we know that Texas stood to actually gain dollars. We would have been on the positive side of the ledger if we had expanded, not to mention that we would have gotten more people covered and gotten them access to care. I do want to real quickly say that in terms of access to care, I think there are huge issues there regardless of whether we expand Medicaid or not, regardless of what we do here. And we have to be addressing those. This is not about just providing health insurance coverage without addressing the access and affordability issues for everybody. And we know we have had a nursing shortage in this state. We know we have a primary care physician shortage. I'm really glad that in this last legislative session, we actually addressed that to some extent. And we put more money into graduate medical education. We put more money into the nursing shortage reduction program so we could get more nurses through the pipeline. We actually finally got TMA and TNA together to make changes to the delegation of authority to advanced practice nurses and physician assistants so that we can actually expand our primary care provider base. So we are working on those things at the same time. But for me, I have not heard any legitimate suggestion of how we could do something differently by stopping the implementation of something that has a lot of unknowns and that will require a lot of tweaking, as most major legislation does. I can't think of a time we don't come back to the state legislature and tweak pieces of big legislation, because there are always evolving things that need to be addressed.
Yeah. Now, Commissioner, you actually have the benefit of being the longest tenured or the greatest veteran politician on the stage. Your time in public elective office goes back before Congressman Burgess's election or Representative Howard's. So you remember how things used to be. You know that the problem we're talking about today, what Representative Howard alluded to, 6.2 million Texans without insurance, 28.8% of the state's population, first in both cases among the 50 states. This is not a new phenomenon. The numbers may be larger because the population of the state has grown, but we've been at the top or near the top going back to George Bush as governor, going back to Ann Richards as governor. Why has this problem been chronic? Why has it not been a problem we've been able to combat before?
Part of it has to do, I think, with the workforce, and we can get more data on, I'd like more data in terms of how many of those folks who are uninsured remain so for a long period of time.
Yep.
In my inaugural TRIB conversation, Emily Ramshaw was actually taken aback when I said, I don't know how many of those folks are chronically uninsured, and that we have built up a system in the state of Texas based on property taxes. You're absolutely right. We built this safety net, going back to County Indigent Health Care Act, whereby we use local property taxes and some matching funds from the federal government
Right.
to sort of create this safety net across all hospitals, not just the hospital districts, but the private hospitals as well. And so we have this safety net that was built over time, over decades in fact, whereas other states don't have that. I've talked to some of my counterparts in other states, and they say, we've got Medicaid and that's it. So
Yep.
yeah, we're going to expand. Texas has an opportunity to strengthen that safety net so that if an individual person is not able to get determined eligible and get enrolled in Medicaid, so there's still something to catch them.
Yeah.
They may have had insurance 2 months ago, temporarily without it, hopefully get it again in the future, but in the meantime, we need to have a strong safety net for everyone, be they in the existing population through the Medicaid system or what would have been the expansion population.
Is the safety net, Commissioner, the emergency rooms that we all
No.
occasionally have to go to emergency rooms? You see they're overfull, very crowded, and a lot of people who are in emergency rooms these days may not have insurance. Is that the safety net?
Historically, that was, and that's a good point. But that's everyone's mental image when you think about
Right.
what folks who don't have insurance do. They go to the emergency room. To some extent, that's the case. However,
But it is the most expensive and
However,
least efficient.
that is,
Right,
and
form of care.
it's the most expensive and least efficient for a particular reason, and that reason is those doctors and nurses in that emergency department don't know that patient. They don't know that patient's history other than just sitting down and taking a short history and doing a physical exam. And so what has changed since that time when the emergency department was the clinic is actually the local hospital districts are now starting to create more clinics so that people are getting primary care, they're getting some preventive care, they're being seen earlier in their disease process, and that's
Yep.
very different. So even though it is, let's say, Harris County Hospital District,
Right.
that doesn't mean that it's only Bentob Emergency Room. And so that safety net gets better all the time. We've got an 1115 waiver, so-called transformation waiver, with the approval of the federal government, wherein the local hospital districts and their private partners in the 20 regions of the state have come together and created these projects that are locally designed and locally implemented, and they're going to have a huge impact. So to go back to your original question, once upon a time that was true. That is not the case by any stretch anymore, and we will see even more outreach for primary care and those sorts of things.
So you think the situation, Commissioner, will improve simply because circumstances on the ground in healthcare have improved?
The locals are not waiting for us. They're not waiting
They're
for the federal
taking
government. They're not
matters into
waiting
their
for
own-
me. That's right.
Right.
They're taking, but because the 1115 waiver conceived and brought into implementation, working with our commission,
Yep.
my predecessor, Representative Garnett Coleman from the Texas House was instrumental in its design. But now we've pushed some of these projects down to the local level and say, tell us what you need in your area. you got a large patient population of diabetics. Let's, you know, let's get the services in there that they need. And mental health, 25% of the projects in the 1115 waiver are dedicated to mental health. It may have gone up from that, maybe 27 or even higher, but it's a big impact.
Representative, you know that much of the innovation in this area these days is bottom up rather than top down. So consistent with what Commissioner's saying.
I did want to say about the 1115 transformation waivers, I totally agree with the Commissioner. These are huge and will have a huge impact on our communities, and they are exactly the way we need to go, where we're having coordinated care. I do want to point out, though, that the 1115 waivers were created and approved with the expectation of Medicaid expansion. This is not increasing capacity to use the 1115 waiver without having done the expansion. So there are questions about how this is going to be, how the funding might or might not continue, knowing that we're not actually expanding capacity in the sense that was originally envisioned. And I will quickly also say, Commissioner Janek and I have had multiple discussions about women's health care and what's happened over the past couple of years here in our state. One of the things in Travis County in Austin, we did have a huge expansion of our community care clinics based on voter approval of some increased property taxes to do that. But again, we made those decisions prior to the refusal to expand Medicaid expansion, prior to the cuts that were made to the women's health program in the previous session. And so, though there is increased capacity in the Travis County area to absorb some of those that were not covered otherwise, the vote that the voters made, the property taxpayers made, was to increase capacity, not to take up what the state was not willing to do.
The assumption, Congressman, both Commissioner Janek and Representative Howard are talking about how all this stuff is interrelated. And a lot of, you make a decision over here, it's connected to a decision over here. Yeah, that's part of the complexity.
Let me just ask Commissioner Janek, how long did it take for Texas to get the 1115 waiver approved? I can remember my state senator complaining to me for at least 2, if not 3 legislative sessions about why won't the federal government consider and approve our waiver for Medicaid. I mean, it takes a while, doesn't it, when you have to go hat in hand to the agency up in Washington and ask for permission to take care of the people whom you know how to take care of.
It can take a while. It can take months and months, depending on the size and complexity of the waiver. It can take months to get those things accomplished, and that's not to diminish the task of the folks at CMS. We're constantly going to them and saying, we would like to change this or change that, and they have to, vet it and see what they're doing in other states, if it comports with regulations that they've passed and interpretations and so forth.
Okay, I'll be politically incorrect. They're an intractable bureaucracy that is impossible for them to move with any facility from point to point, and that is the difficulty. You have constructed a program in your safety net program in the state of Texas. Obviously, I participated in that when I was a practicing physician. Fully 20% of the deliveries I did every month were uncompensated in any way, shape, or form. So we all participated in that, and I applaud your efforts to try to bring this into modernity. But the fact of the matter is you're stymied by the federal government. Why in the world? And Governor Perry and I are not always on the same page. Let me hasten to point that out. But on the Medicaid expansion, I think he was exactly right. Because as you like to talk about the Affordable Care Act being the law of the land, remember there's another law of the land that is inconvenient for the president and he doesn't like it. And that's the law called the sequester, the Budget Control Act that passed 2 years ago this August. The Budget Control Act provided for across-the-board cuts in discretionary spending, both on the domestic and the defense side. So everyone now is talking about turning off the sequester. It's too tight, it's too painful. And yet, what is going to happen in the middle of October? There's another debt limit fight, and this debt limit fight is likely to be every bit as desperate as the last one. You can't cut more money from defense. You can't cut any more money from discretionary programs. You're going to have to look to the entitlement side. So I think Governor Perry is correct when he says, if I expand Medicaid, what does the next sequester look like to the state of Texas? And that's a very real problem. It'd be great if the money were unlimited, if the spigot would just never be turned off. But I got to tell you, there are some pretty hard fights coming up. Yep. The government is $17 trillion in debt. All of that is borrowed now from some other place that doesn't care for us. There is a feeling that that is the greatest national security threat that faces our country. And as a consequence, it will affect what happens with the Medicaid expansion.
And that, Congressman, is at the heart of the tour that Senator Cruz has been doing around Texas. He's saying defund the Affordable Care Act, and if we don't defund it, then we ought to shut the government down. He is a vote to shut down the federal government.
No, that's not accurate.
It's not?
No, pass a bill that funds every other discretionary aspect of the federal government, but don't include money for the implementation of the Affordable Care Act. The House will pass that bill in early September, I hope, and send it over to the Senate. Senator Cruz, if he's true to his word, will make certain that nothing comes out of the Senate that is different from what the House has proposed. If the president wants to shut the government down, then that's his prerogative.
Okay, so you're basically backing into exactly what I said, but you're putting the onus on the president for not going along with what Congress wants, rather than saying that what the Congress is doing is walking up to the knife's edge here.
Under the Constitution, the House of Representatives does control the purse strings.
Right.
And again, I alluded to another couple of examples. Certainly the Boland Amendment in the mid-1980s, Edward Boland from Massachusetts, who restricted any money that the CIA might use for the Nicaraguan Contras. That created a great deal of difficulty for the Reagan administration.
But you don't dispute the fact that the net effect of this jujitsu legislatively that will happen over the next couple of months is that we're threatened by another, or threatened with another government shutdown.
No, we're threatened by the enormity of our public debt. And
You're also good, by the way, just as Commissioner Janek.
If you want to talk about taking care of people who are of limited circumstances, look, if the Bureau of Public Debt 1 week cannot sell all of the Treasury bonds that go down there, and the interest rate has to go up, and it goes up in a staggered fashion, but relatively dramatically, that's an inconvenience for you and I, our house payment, our car payment. But the people at the lower end of the income strata, it's devastating for them. So it is important that we get these debt numbers correct, and that's why, correctly, we will have these debates on both the discretionary funding at the end of September, and then sometime in the month of October on the fiscal debt limit.
This issue is important enough to you that if the result of it is that the government is shut down temporarily, so be it. Whether it's the Congress or the president that flips that switch.
Or bondholders in New York. I mean, there's someone.
It's that important.
It's the greatest threat to our national security is our unresolved debt problem.
Let me get to what Representative Howard alluded to, which is the amount of money that would potentially be available to the state of Texas if we were to embrace some, I guess expanding Medicaid is the bad way to say it, leveraging of federal dollars is the euphemism. Let's use the euphemism. Mr. Perryman, who sits before us, I read a bit of commentary by him yesterday that suggested that it might be $250 billion to the state of Texas over 10 years would flow into the state. Now, by comparison, we just spent an entire legislative session focused on a $50 billion need for water over 50 years and a $200 billion need for transportation over 10 years. This is potentially a $250 billion injection into the economy over 10 years. 100% of the costs covered through 2017. I believe that they have to go to 90% by 2020. And eventually the faucet does turn off. But it's a lot of money that we would be walking away from as a state if we just decide we're not going to do anything with the government. Have I characterized that?
Well, what guarantees
properly?
that faucet is 100% coverage on the federal match for state Medicaid? There's no guarantee for that. And what happens if the money dries up? What happens if there is no money to apportion out to the states?
So it's a promise now, but there's no guarantee that the promise will be made, essentially.
And when has that ever happened before at the level of the federal government? I mean, here's our problem with unfunded liabilities. We've made all kinds of promises to ourselves that we can't afford to keep. And this is just yet another one in that long line of promises. The fiscal sustainability of current entitlement programs is, I mean, you guys write about it, it's an open question. If you look at the long-term liability, Medicare and Medicaid and the Social Security system, it's enormous. 75 or 95 trillion dollars over the lifespan of those entitlements. You're adding one to that could easily be half again as large. And how can you ask the American people to carry that weight in their for future generations? I'll never forget, 20 years ago, I came down to Dallas. My hospital administrator made me come listen to the Dallas Business Group on Health. It was a senator from Massachusetts named Songas. And I thought, what in the world do I want to go listen to a senator from Massachusetts who was an unsuccessful presidential candidate the year before? This was a day or two after President Clinton gave his beautiful speech on the Health Security Act. You may remember that, joint session of Congress. And Senator Tsongas got up in front of this group and said, I hope you all heard the president's speech. It was a beautiful speech, not a dry eye in the House, because he brought up 5 new entitlement programs we can't pay for the ones we got. I thought, wait a minute, what did I just hear? I thought this was a Democratic senator from Massachusetts. But he outlined that over the next 20 or 25 years, because of the unrestrained growth of entitlement spending, this country is going to face an intergenerational crisis, an intergenerational transfer of wealth crisis, unlike anything we've ever seen before. That was 20 years ago. I was 40 years old. I'm 20 years older now. We are on the precipice of that crisis that Senator Tsongas outlined for us many years ago. And unfortunately, no one, Republican or Democrat at the federal level, has done one thing to stem that crisis from happening. So you look into the eyes of the college students of today and realize, I'm hoping that they don't figure out that they really don't have to pay for me in the next 15 or 20 years, because at some point it may occur to them that that's the case. And when I talk about the money stopping, that's the type of thing I'm telling you.
Representative, talk about the money left on the table and also what the congressman is alluding to, the possibility that no matter how much money is offered to us, at the end of the day, we're not going to have it to
Well, you know, I would suggest that there are many of us, Republican and Democratic, who want responsible government. And that means that we need to be looking at both the revenue streams and the expenditures and making some hard decisions. That's been part of our problem, is that we haven't been making those decisions, both at the state level and at the federal level, though I won't speak too much for the federal, because I'll leave that to the congressman. But the fact is that at the federal level, in all of these discussions, there have been multiple bipartisan efforts to address that, to address the debt, to come up with some very hard decisions, make decisions about things that we need to cut and new revenue that we need to bring in. And you can't get off the dime to make any of those things happen. But also the idea of, you know, you have to have some absolute guarantee of what the future holds. Well, I don't think any of us expect that that's really the case. I'll give you an example here in Texas that we at the state level did. We have been telling the school districts for years and years, this is your funding formula. This is how much money you are guaranteed. We will make it whole. We'll plug your district into this formula, and you will get that amount of money. But the session before this, we decided that we were going to change that funding formula midstream and pay less. We didn't actually change the formula. We just appropriated less than what the formula said the schools were entitled to. Well, the schools were counting on that, and we didn't have the money, and the schools had to make do. And we've made it through those past 2 years, and we're at a better place, thank goodness, and we've appropriated more funds, and we're moving forward. But my point is that there are no guarantees. We need to be working on this responsibly together to come up with how can we make this work, rather than let's just turn it off and not do anything here. That's not a sustainable thing either, to just say no and to just pull the rug out from under everybody. Remember what it was like before we went into this Affordable Care Act period of time. We had double-digit increases in insurance rates, and businesses were complaining right and left about what was going on. People were not able to afford their individual insurance. People didn't qualify to even get insurance if they had the money because of pre-existing conditions. We had all kinds of things going on that people were complaining about that seemed unsustainable. Well, this is one way to work on it. It's not perfect. I don't think anybody thinks it is. There's a lot that needs to be done. But we need to be working on it together and coming up with some solutions proactively, instead of what I know in our state we've been having to do is not help, not necessarily get in the way, but we're not proactively out there even helping our Texas citizens understand what their options are, because we're not participating. So we're having to leave it to faith communities and nonprofit groups and community clinics to help people get enrolled, because as a state, we're not participating.
Commissioner.
Let me interject something, because I think there's a general misconception, not with these folks and not with you, but there's a general misperception that there is some big pot of Medicaid money, and if Texas does not avail itself of that money for Medicaid expansion, when I use that term, I'm talking about the new population under Medicaid expansion, as the Supreme Court looked at them very differently than they did other populations. So there's this idea that there's this big pot of money, and if Texas doesn't get it, other states will, and that's just simply not true. It is patently false, and we've had elected officials from counties come up and testify to that if we don't use this money, California will get it, and that's just
Right.
not the case. Every dollar that is spent that would not have been spent is added to the national debt. There is no dispute about that, and that is money that's borrowed from China and from other places. So to tie these things together, discussion of the debt with the entitlement programs is a very, very important issue. Let me say that right now with 100,000 people, disabled Texans, on waiting lists for certain services, a lot of our focus is at the commission is trying to get some services to those people who are disabled, much less what we can do for those folks who are able-bodied and current gainfully employed. As to the participation, Texas made the decision to, when the federal government came with the exchange, they said, okay, 3 ways to do this. You can have the state-run exchange, which in fact, when you look at the rulemaking and the requirements, you got to do this, don't do that, don't do the other thing, basically ended up being pretty much a federally run exchange, or a hybrid, state, federal, or a federally run exchange. Texas decided to say, if you're going to go ahead and tell us how to run the exchange, why don't you run the exchange? So my emphasis, our emphasis now collectively at 4900 North Lamar Boulevard is to say we've got to get ready for October 1. It's coming, it's the law. We've got people who are assuming it's going to be funded, and we've got people who will be going to the exchange and actively signing up on January 1 for coverage.
Well, and what is the
We're busy
price? So people in
implementing
this room, these are smart people who understand more about healthcare than the average audience
that's
might be before. Prepare us mentally for October 1st and January 1st in terms of what the federal exchange coming online means.
What we have to do on October 1st is the state has to be ready with all the criteria that will be effective on January 1. So January 1, instead of signing somebody up under the old Medicaid eligibility criteria, we will now use one that is more decided by the federal government, the so-called modified adjusted gross income. And in simple terms, one piece of the magi is that back in the day, which means today, Texas defines what a household is. So your eligibility for Medicaid is based on your household income, and Texas defines who is and is not considered to be a member of the household. Well, the feds have taken that away. They've now decided here's what a household will be composed of. And so on January 1, the MAGI criteria take effect. Between October 1st and January 1st, we're to do both. We're to implement the MAGI criteria. We will also implement our existing criteria, so we're trying to avoid having dual systems. It's to be a transitional period, but in fact, transition would only be in that we're running 2 systems, and we don't want to do that. It's enormously expensive to get ready for something on January 1st. So new criteria in terms of who is eligible, some requirements by the Fed that we cover populations who are not currently eligible under Medicaid. Quick example would be former foster care. The state of Texas has provided, through our STAR Health program, health insurance to kids who are in foster care. The idea is pretty straightforward, right? If a family is willing to be foster parents and you've got this kid who has health insurance needs, the state is willing to pitch in and help that family with the kid's health care needs through the STAR Health. Now, when the kids age out of foster care, so they turn 21, they're at the age of majority and they're gone from the home, Texas will continue to cover voluntarily with straight general revenue, has continued to cover some of those kids as long as they're enrolled in an institute of higher education, and cover them up to age 23. Texas has done that with straight general revenue, not anything that somebody had to do, passed by the legislature, signed by Governor Perry, and voluntarily covers those kids because it's the right thing to do. Come January 1, we will be required to cover all former foster kids up to the age of 26. That's to make it comport with the general requirement that kids can remain on their parents' insurance up to age 26. So there's a bunch of little things like that. That's right. A bunch of little things like that are going to happen that are hard to even anticipate.
On the exchange issue, Commissioner, I was interested to hear you say that it's basically a state exchange was one option, but we'd be given so many mandates in the course of setting it up that it was effectively a federal exchange. Or we could do a hybrid, or we could basically say, okay, we throw our hands up, you all want to come in and do it, you do it. This is a state whose position historically on matters like this has been, we don't want the federal government here. It feels to us from the outside that by electing not to create a state exchange, we are inviting upon ourselves the very thing that we detest, right? We could have set up a state exchange, but instead we're allowing the federal government to come in, and I thought that's the thing that we hated more than anything in the world.
Right, but when you look at the things that would be required, it essentially follows all these federal mandates anyway.
Yeah.
I'll give you a quick example. Utah already has its own exchange, and I forgot, in terms of our dollars, it's relatively small.
Right.
Just because of the population and so forth. Utah had its own state exchange, and they've got to scrap it. They've just got to go with what the feds have told them. So they had a state exchange to do exactly what the
But
exchange
it wasn't
supposed
working.
to do. No, it wasn't working. It was working, but it wouldn't work under the new Affordable Care Act. The feds have said
Right.
you've got to have plans in your exchange, and those plans have to be this. Here's the minimum benefits to be in the exchange and so forth, and that gets expensive.
Congressman, I know that this is not just about process. I don't want to diminish your opposition by saying that this is all about process and procedure. But I know that that's a large part of what the objections have been as stated thus far. I want to ask you as a medical professional, because the benefit of 3 medical professionals up here, do you disagree with the principles baked into this legislation, leaving aside the politics and the complications created by the implementation? Things like no pre-existing conditions, things like insuring kids for a longer period of time on their parents' insurance. The things that are more about the health care as opposed to the implementation of the process. How do you feel about those?
Well, the state had its own risk pool for a number of years.
Yeah.
I can't honestly say when I was in practice that I took care of anyone who was covered under the state risk pool. I know for a fact I never got a reimbursement check, but it still worked. And when I would go around the state and talk about things, invariably someone would come up to me and say, whatever you all do, don't mess up our state risk pool because it's working well for me. There was a perfect opportunity with the implementation of this thing to say, okay, the 35 states that have done your own risk pools, we're going to help you. Rather than set up an entire new federal agency, rather than spend all the money on new bureaucrats and new typewriters and typewriter ribbons, I guess they don't do that anymore, but still, we could spend all that money on helping the states bring people onto their exchanges. And those 15 states that don't have a risk pool or a reinsurance program, allow them the opportunity to bring those patients into their own state Medicaid, or maybe even cover them if the numbers are small on their state, the same as they cover their state employees. So there were ways to work around this. But at the time, 2009, 2010, there was intransigence. No one wanted to do that. We want a federal pre-existing program. So you got it, a federal pre-existing program. You know what the big problem with that is right now? They closed their doors to new applicants February 1st. Now, the statement was that, well, by January 1st of next year, we'll be up and running with the Affordable Care Act, and there will be no pre-existing conditions. But tell that to the person who right now is uncovered, who thought they were going to be able to buy into this federal pool, and then had the door closed on them. So when I say the promises made are not necessarily the promises kept, this is speaking from real experience. We've had people before our committee who've told about the problems that they've had. Now, you could have fixed that. You could have fixed that really with an administrative application, because what was the real problem with patients with pre-existing conditions? It was the fact that we don't treat the individual market and the small group market the same as we treat the large group market. Problems with pre-existing conditions only occur generally in the small group market or the individual market. This could have been fixed administratively. I know this because right before the Supreme Court ruled, and I thought it was going to go the other way in fairness, but right before they ruled—
I think we did too.
Right before they ruled, I thought we got to be prepared to deal with kids on their insurance till 26, pre-existing conditions in the donut hole.
Right.
The kids on their parents' insurance till age 26, 3 or 4 of the largest insurance companies 2 weeks before said, you know what, it's good marketing strategy, we're not going to deviate.
Just do it, yeah.
So the pre-existing really was the main conundrum. And it was going to be very difficult to deal with this federal program that had been set up that now would not exist. So I began to look at how many people are going to be affected by this. As of the end of June of 2012, it was 65,000. You tell me we can't deal with a finite population of 65,000 people who are in trouble? I mean, and it doesn't require $2.6 trillion and messing up what everybody else has.
I think it could have been dealt with in a different way and more inexpensively.
Absolutely, and Senator McCain talked about this in 2008. He said, let's help the states that are doing their individual risk pools. So what have we got now? The federal program is not accepting new applicants. If something does happen to the Affordable Care Act before January 1st, there will be no coverage. But Texas also lost its risk pool along the way because the state legislature in their wisdom said, look, it's going to be covered under the Affordable Care Act, so we're going to do away with it. Was there any funding for the risk pools in the last legislative session? I don't think so. So it's gone. So what do our constituents in the state of Texas who have pre-existing conditions, if they've bet wrong on the Affordable Care Act and it doesn't work, when I talk about pieces being thrown over the side, nobody recognized when they closed the door to people with pre-existing conditions in the federal program, nobody recognized that that was a significant deviation from what had been promised when the Affordable Care Act was signed into law. The president made a big deal about it. No longer will people with pre-existing conditions. Well, for the next 11 months, Mr. President, they're in a world of hurt.
They're in a pickle. As a medical professional representative,
Yes.
the aspects of this that are not on procedure or process, but the things that are supposed to improve people's access to care, health, and all that, those principles speak to you.
Oh, absolutely. But I can't get totally away from process. I have to respond to some of what the congressman was just talking about. The fact is that, yes, we have had this high-risk pool, but it was extremely expensive. And so we still had a huge number of people who couldn't access coverage. So, I mean, I think the congressman makes a lot of valid points, which, going back to process, is why we needed to have more discussion, why we needed to be, I think, meeting the federal government at the table rather than just, putting up a cold shoulder to it and saying, no, it's going to come anyway, but we're not going to have anything to do with it. I think we could have had, we did have a proposal for the Texas solution.
There was a discussion.
There was a discussion to come up with a Texas version of how we could use the Medicaid expansion dollars to craft it specifically for our state, to make it workable for our state. And in fact, again, referring to Mr. Perryman, he showed that that was even going to give us more return on our dollar investment. We had bipartisan majority support, at least on the House side. This was carried by a Republican physician in the House and a Republican physician in the Senate. It was doable. It was workable. We could have been working on that right now. We had majority support, but because of the politics and because of the governor's threatened veto and whatever else was going on, even though we had the votes on the floor, the last count that I heard was in the 90s out of 150. We couldn't get the vote. We couldn't get it to the floor to even take the vote. So, I think the process is unfortunately tied up in all of this, and it's a huge part of what happened.
Well, in fact, the upshot was that you all didn't just refuse to negotiate. You actually took a step back from there and said that we're going to tie Commissioner Janek's hands.
That's correct.
In his ability as our designated representative of the state to go to federal government and say we want to negotiate on some deal that we can live with. The legislature basically said we don't trust him enough to do that by himself.
We need
to be in the room with him to be sure he doesn't get all gooey in front of the administration.
As a matter of fact, it's very right. You just succinctly described both the rider that was in the original Senate budget as well as the efforts on the House floor and what came out through Representative Leach's amendment. And so as a former lawmaker and now a bureaucrat, I would counsel any lawmaker, don't give me unfettered ability to just go up and cut some deal that I want.
So you supported this idea. You needed a chaperone.
It is up to the lawmakers to have the final say on these things. And so I would argue that what the legislature has now done doesn't keep me from negotiating something that may seem workable, but that the legislature is going to get the final say.
Have to have a place at the
and
table.
They represent the people.
Right.
I wasn't voted for by anybody.
Well, so to that point, you're the governor's designee in this position. And you may not be in the position to set policy. You kind of carry the policy recommendations or decisions of others forward. But you are in the middle of this conference. I want to ask you about this phrase Representative Howard used, and Secretary Sebelius was in Austin recently and used it as well. We are willing to come up with a Texas solution.
Right.
To me, a Texas solution sounds like healthcare smothered in barbecue sauce. What does that mean exactly? What is a Texas solution? What does that mean exactly? When you talk about that, or when Secretary Sebelius talks about, what exactly is that?
I think it's an apt description of our ability to come up with something that fits our state with the resources that we have, the money. By resources, I mean the medical schools and FQHCs and all this sort of thing. So I would argue that it's not one thing, It's a bunch of little things that add up. Recently, I was up visiting our friends at CMS and asking for permission. One of the things that we want to do, and we would argue we don't even need legal permission. It is already permissible. What we want to do is take some of the money that's been appropriated to the state-supported medical schools, to health-related institutions. We'd like to take some of that money, get a federal match for it, give it back to the health-related institutions with the proviso that it goes into primary care, educating the next generation of doctors and nurses who are going to be the front lines in primary care. The federal government said, yeah, we can't do that. It violates a regulation. We disagree. As a matter of fact, we've done something virtually identical
Yep.
at UTMB in Galveston for decades. We've taken UTMB state money, gotten a match, getting it back to the University of Texas Medical Branch. It's virtually identical, except it's not even constrained by doing more in terms of primary care. And the federal government's balking. We're not through with the discussions. We'll go
Right.
back and say, pretty please. But it's not the one big thing that's a Texas solution.
It's lots of little things.
It's a bunch of little things. And when I can't even get past that little hurdle,
Yeah.
it gets frustrating. for me.
Congressman, I want to ask about that because well, yeah, you want to say something. Let me, go ahead. I know, I'm in the position of asking questions and you giving answers, and I should actually let you go ahead and
Well, we do need to talk about the Medicaid expansion. Commissioner Janek is exactly correct. Under the law, the states were required to submit by a time certain their willingness to participate in the exchange.
Yep.
They were given a couple of extensions on the deadline because the essential health benefit rule didn't come out till 2 days after Election Day, which was 5 days before the first deadline. They got a couple of extensions, but finally in January, the federal government said, we got to know which of you are on board. No great surprise, 26 states said no thanks, and 6 other states said some kind of hybrid, but you set it up. But on the Medicaid side, remember, that was not a legislative activity, that was a court opinion. So as a consequence, there is no deadline. So the state of Texas is now done with its legislative session, I think, for this year.
Right.
But there is nothing to say that at a future session of the state legislature, they can't look at the experience of another state that has set up a program that Texas might consider. There was
Arkansas, say, which is often as an example that people hold up.
well, whatever. But there's nothing to say that Texas can't come back and then renegotiate or relitigate this problem. There was no time certain by which a state had to say, we're all in on Medicaid expansion.
So maybe we let other states work this through, and then we basically see how they do, and maybe we find something in that we like.
Again, I can't argue with the governor for being cautious on this one because I think the federal government is an unreliable fiscal partner, and there will be the opportunity to see what happens in the right amendment states.
Representative Howard, I'm remembering that a number of red states with red governors made the decision to go at this differently than we did. You know, I'm remembering Governor Sandoval in Nevada, Governor Scott in Florida, Governor Snyder in Michigan, Governor Christie. You may not think he's that red, but Governor Christie in New Jersey.
He's as red as it gets in New Jersey.
Even the governor of Arizona, the woman who famously wagged her finger in the president's face on the tarmac there, even the governor of Arizona made the decision that it was a good idea to do this. Why was it right for them to negotiate and wrong for us? Or, to the congressman's point of view, aren't we being more cautious, more prudent in saying, you all go first, be the human shield, basically, for the rest of us. You work this out, you suffer the slings and arrows and all this, and then maybe we'll come behind and learn from what you...
Well, actually, that's not typically how Texas does things, but certainly that is an option. We could do it that way. I mean, if you look at going back to education again and the national standards, one of the things that Texas did was we went to work and developed our own standards and curriculum, and now we're not wanting to participate in the national standards and core curriculum because we say we've got a Texas specific, we want it our way. You know, it's not like us to watch what everybody else does and then come up with something. But at the same time, I think there's value, as the congressman is mentioning, in looking at what works and what doesn't work, and we can learn from that. And yes, indeed, we can come back in 2015 and make some different decisions, and I'm hoping that we will do that. So, you know, yeah, I think
This is not done.
no, it's definitely. And one more thing. I'm sorry about the Texas solution. I wanted to make sure I pointed out another part of the Texas solution. one of the things that was being looked at, one of the major things we were looking at was instead of using the federal dollars to, you reminded me with your other governors you mentioned, instead of using the federal dollars to expand Medicaid as we know it, we were going to take those funds and actually use them as subsidies for these newly eligible folks and get them insurance on the private market. So, you know, this was trying to work within the private market system, which some people feel is going to provide better coverage than what we were doing with Medicaid. And so it was really a hybrid that we were looking at there that was very Texas specific. And that, you know, as I said, Ray Perryman also found that that was going to bring more dollars back to our state if we did that. So I think, though, we still have these options before us, some things we can do, and I hope that we will.
Commissioner.
A couple of points on the implementation. Again, because of the changing field, the various interpretations of the regulations, you know, we'll get 12 pages of frequently asked questions that go out to the states, our weekly state-operated operations technical assistance, or SOTA calls that we have with the federal government. So we'll get 12 pages of frequently asked questions and then dozens of pages of clarification to the answers to those frequently asked questions. It matters, and it matters a lot in terms of the money. We're going to spend we sort of estimate a couple $100 million on things that we didn't anticipate, former foster care, kids, and that sort of thing, leading up to January 1st and getting ready for January 1st. So there's a bunch of those kinds of things that are going to cost money, and it's not entirely unreasonable to be cautious and say, let's see what the ACA is going to do to us in terms of the overall budget before we take on more in the future. Quick word on those other states. Those other states, again, many of them don't have a safety net program. Medicaid is the safety net, and they choose to expand. There are very blue states with very blue governors who are saying, boy, we sure could, we'll do it, but we need some flexibility in certain things. We're actually the human shield. Texas has been at the forefront in the advent of managed care into the Medicaid program. We now have managed care for acute care services throughout the state, managed care for the STAR Plus, those acute and long-term services throughout the state. Next year, we'll start to implement acute and long-term services in managed care for the individuals with developmental or intellectual IDD. I'm sorry, I'm having an oops moment. Anyway, for those folks that reside in the state-supported living centers and other areas with intellectual disabilities is the word. And so we're at the forefront. We're doing all these things. What Governor Christ asked for in Florida was basically what we already do. That doesn't help us. We need something different to manage this expanding population with expanding costs attached to it, and we need to do something fairly soon.
Okay, well,
You do have to ask yourself, when this thing was written, where were the governors? I mean, you had insurance companies in the room, you had hospitals in the room, you had the pharmaceutical manufacturers in the room, but you didn't have the governors. And Governor Herbert from Utah is probably the prime example of that. I mean, in one of our congressional committees said, I felt like I was walking on shifting sands. I'm trying to set up an exchange before the Affordable Care Act is even thought of. And even with that degree of expertise and willingness to do it, it couldn't be done because of the changing landscape brought by the Affordable Care Act. But had you invited the governors in, you might have learned something useful. Mitch Daniels in Indiana held the cost of his state employees program. It fell by 11% over 2 years. At the same time, every other PPO, HMO, Medicare, and Medicaid was going up 7 to 9% per year. And how did he do that? He funded, it was a voluntary program, but anyone who wanted a high deductible health plan got one. And then he put the money in for the health savings account to cover the deductible. And if it wasn't spent, it rolled over to the next year. It wasn't taken back. And as a consequence, he found out that something magic happens when people spend their own money for health care. They become informed consumers, and they make rational decisions in their own self-interest. In none of our hearings did anyone recommend that we bring Governor Daniels in and chain him to the table until he spilled the beans about how he was able to hold the cost down in his
secret
state.
sauce? Yeah.
But it was so simple that you know, people looked beyond what was a very reasonable solution. And as you know, a consequence in the Affordable Care Act, I've had a health savings account for 15 years, and I probably won't be able to continue one next year because the actuarial value of it or the medical loss ratio won't compute. And as a consequence, those types of accounts are going to go away. Look, the president himself talked about one time down at the White House, he invited all the Republicans down 2 years ago, right before the last debt limit, and said, I just want to give you an example of how expensive health care is. When I was a candidate and running for office, I got a rash on my back. And I was prescribed some stuff to put on it. I had a copay card, it cost me $5. So I used it, didn't really help. I got it refilled, still didn't help that much. And then I'm out on the campaign trail. Michelle calls and says, are you using your stuff? And he said, oh, I gotta go get some. So we went to the pharmacy, and through the miracle of electronic transfer of prescriptions, he was able to get his prescription filled. The pharmacist bagged it up, handed it to him, and said, that'll be $495. And the president said he looked at the pharmacist and said, this rash is not that bad. Well, exactly right, Mr. President. You became an informed consumer at that point when you were given the information of what this stuff actually cost, as opposed to a prescription card, a discount card, and he made the rational decision not to proceed with the prescription any longer because it wasn't helping anyway. And these are the types of decisions that people can make every day on their own, and they're rational and informed decisions.
All right, let me let you have the last word. About presidential rashes or anything else, go ahead.
No presidential rashes.
It doesn't violate HIPAA because he told us in an open forum.
So we know it's actually true, no violation.
But no, in terms of personal decisions, you know, the other part we have to be thinking about as we make all of these decisions is it's not just about the health care coverage, it's about what consumers do decide about their own health care. And the fact is that we know that a large percentage of the costs of an individual's health care is in the last few months of their life. We know that a huge number of our conditions that we're having to treat are based on lifestyle choices that we make in regard to obesity, in regard to exercise, in regard to drinking, in regard to smoking. Those things have got to be addressed in some way. End-of-life issues have to be addressed in some way. These are driving up the cost of health care. They're all about what individuals and consumers decide, and we're not going to be changing the overall cost of health care just by providing insurance and even just by providing access. We've got to address those things as well.
All right, so we're going to do excellent. We keep going. A lot more to talk about, but we've got questions, hopefully, from the audience for about 10 or 15 minutes that we'd like to invite you to join us. We have a microphone here. We'll walk around to you. If you've got a question, put your hand up. And, sir, appreciate you taking the bait.
Well, good morning. Thank you very much. Very stimulating discussion. One thing I didn't hear talked about, though, is we're talking healthcare, but we see a lot of healthcare issues are really social issues. And so how do you incorporate a lot of the social needs that these people have? Transportation. People can't get dialysis, or they can't get to their doctor, so they call an ambulance to get to the ER. I mean, that kind of issue is a huge issue as we as providers begin to understand some of what's driving the cost.
I think we alluded to the idea, Commissioner, that healthcare touches every other issue out there.
It does, and we have a fairly robust medical transportation program in the state. So we through various means, maybe it's a bus token if somebody lives in an area with mass transit, maybe it's a cab ride, maybe it's paying a family member. So we've got a fairly robust medical transportation program to help people get there. It's mandated by the feds, it's part of our access. It doesn't always work, and sometimes it's subject to fraud, and we have to watch those things very carefully. We're now, because of the actions of Senate Bill 8, we'll revamp that medical transportation program and go to, again, a capitated risk, a managed care type model. So we will contract with an entity who will then set up the networks in those various areas to make sure that people can get where they need to be. We watch very carefully so that if an ambulance takes somebody to dialysis, they're not getting paid that full amount as if it were a true medical emergency. Dialysis is an interesting thing, because there's no disputing the diagnosis, and there is no disputing the treatment, which is 3 days of hemodialysis every week. And so I want to see that we dial back the regulatory oversight of that just a little bit so that we're not saying, prove this person again is the same person who's been going to dialysis for the last year. We do some things that are sort of bureaucratic stumbling blocks to that, and I want to dial some of that stuff back. Your kidneys have failed. They will not get better next week. They will continue to be failed in almost all cases. And so we ought to say, until you get a transplant or something miraculous happens, you'll be going to dialysis. Let's just set up a system so that it happens automatically. But you're right, we have to watch medical transportation costs very closely. We do think we have a robust system, but it's always subject to improvement.
And I would say that one of the aspects that's come out of the Affordable Care Act is this movement toward the accountable care organizations and even the efforts with the 1115 waivers, where we are looking at having medical homes for patients, having navigators for patients, looking at the entire aspect of what's affecting the health care of that patient, and that's a positive thing. We need to be looking at it from that vantage point, because it's not only transportation, obviously, it's about having a walkable neighborhood. It's about having access to healthy foods in your community. It's about all kinds of things. And when we have more coordinated care, when we have a team approach to how we're addressing the healthcare delivery, then hopefully those aspects of care will also be a part of the plan.
At the risk of sounding misinformed, what are your opinions on the states that have opted out of Medicaid expansion being southern states, and how they're dealing with it with lotteries and other things like that?
Well, the lottery was actually Oregon, and that was before the Medicaid expansion. So that's sort of an interesting side experiment that was conducted by a Democratic governor in Oregon, and many people have written about.
Blue state.
And many people have looked at that and written about what is the real value of providing someone Medicaid coverage, and maybe it's different from what people assumed. Otherwise, I don't have a firm opinion for you. I do think the Republican governors that have embraced Medicaid expansion, interestingly enough, are in states that President Obama carried in the last election.
Does the South hate health care, Commissioner?
Say it again.
Does the South hate health care?
No, of course not. We've invested large amounts of our infrastructure. When you look at where, again, to go back to our medical schools, our health-related institutions, we've got those in the major population centers, soon to be in Austin, soon to be in Rio Grande Valley. We're now up and running in El Paso. They broke ground last week on the new nursing school in El Paso. So these institutions where folks live, and I could argue a majority of the Medicaid recipients live, are an important part. Those are due to the infrastructure investment by the legislature through the years. Republican legislatures, Democratic legislatures, governors alike. And so we look at what other states do with an eye towards could that work here? But we also have to look at the resources that we have and say, does it fit with what we want to do?
Yeah. Well, but I don't know what the factors are here, and it would just be opinion to state something. But I will say that as far as Texas goes, we have one of the lowest expenditures per capita of any state in the union. And I don't know how that compares to some of these other states that you're referring to, but we have made the decision in this state that we are going to be a low overall tax burden state, low regulation state, and low services state. And that's the way it is. And with the lack of access to providers, part of that has been because of our unwillingness to pay a higher reimbursement rate to providers. We've been paying one of the lowest reimbursement rates in the nation as well. And when people talk about access is a problem, we don't have enough providers, well, we're the ones at the state legislature who have been making that happen by not reimbursing at a rate that's higher, that attracts the providers to actually provide the services.
Final question, sir.
Thank you. Hi, I'm the father of 2 children with pretty severe intellectual and developmental disabilities. And for my family, the biggest thing to come out of this past legislative session was the passage of SB 7, which moves us to a managed care model for people with developmental disabilities. It also calls for, I believe it's like $100 million out of the Affordable Care Act for the community first choice option, which is huge. So thank you to every legislator who voted to approve that and move forward with it. My question more is really for Commissioner Janek. When you look at the implementation of SB 7, which is like a really, really big deal, I mean, it has huge moving parts to it. What do you see as the biggest challenges and the biggest hurdles that are going to be overcome in order for us to move to a managed care model for people with disabilities?
Probably, and as the gentleman stated, and I alluded to this earlier, we take those folks who get services through the state, those folks who have intellectual and developmental disabilities, and we provide services to them. We're doing that in a sort of a straight fee for service, and we're going to move to a capitated basis, a capitated model, managed care model for them. I would argue that the biggest hurdle has already been overcome, and that was because of the work of the House and the Senate and Chief Deputy Commissioner Chris Traylor in our shop, who met with the stakeholders and spent a lot of time with stakeholders in meetings all over the place, discussing what this is going to be about and getting input from the stakeholders, to suddenly take those parents who have kids, and that's usually how this works out. You've got a parent with kids that they're concerned about, and to say, by the way, we're changing the deal on you, is a recipe for disaster. You've got to get them in. You've got to have that input. Parents, rightfully, historically, it's universal, will fight tooth and nail if something that affects their kids adversely is on the horizon. And so Chris Traylor, Jamie Dudensing from the Lieutenant Governor's office, Jennifer Deegan in the Speaker's office worked tirelessly with the stakeholders. That, I think, was the biggest hurdle. The rest of it becomes a bureaucratic administration thing. We roll it out. We talk to the managed care organizations that are ready to take on that population and give them the services that they need and tailor the services more directly to what those individuals need. We have great hope for this. It's not just saving money. It is providing a better model of care. And I think you'll be pleased. I believe you'll be pleased. If you're not, we need to hear about it, where we slip up.
Well, this is a great conversation. I feel like we got into a lot of big issues and did it with respect and civility, which is a nice change, right? But actually, we got into it with a lot of substance, and I think we all came away from today. I did at least smarter about these things than we did when we came in. Let's acknowledge and thank our panelists, Congressman Burgess, Representative Howard, Commissioner Janek. Thank all of you. Thank you again to the Blue Cross team for hosting us today. We appreciate it. Thanks very much.
At Blue Cross and Blue Shield of Texas, we understand the value of uniting in conversations that can bring clarity and guidance to our healthcare industry. That's why we're proud to join efforts with Texas Tribune on public forums like the one you're about to see.